Hello everybody, we're going to start at 12:30, so welcome. This is the COVID-19 question time transplantation webinar, but we'll be with you properly at about 12:30. Thanks very much for joining us today. Hi everybody, there is sound in answer to that request. We're just going to start in a minute. We're just waiting for everybody to join, and we'll kick off at 12:30. And as if by magic, I look at my clock and it is actually 12:30. So welcome everybody. I can see there's lots of people joining. If I look at the bottom of the screen, it's really good to have you with us today. I hope you can hear me okay. I'm going to be introducing people for our session this afternoon. So this is question time on COVID-19 and transplantation. And we're supported for this webinar by us at Kidney Care UK, the Renal Association, the British Renal Society, and the British Transplant Society. If any of you are on Twitter, we're using hashtag COVID question time, as you can see on the screen. We're at Kidney Care UK. We have had lots and lots of questions, and I hope that through this hour, or possibly hour and a bit, depending on how it goes, we'll be able to address some of them. So yet again, thank you very much for joining us. And let's do a few introductions and a few details about how our session is going to run this morning. Thanks, Julie. So I'll introduce everybody in a second, but before we do that, there's just a few things to say. So at the bottom of your screen, you'll see alongside the participants, there's a chat function, and there's also something called Q&A. If you could put any of your questions in the Q&A box, that's better, because we'll be able to address those and you'll be able to see the answers, and that's what that one's for. If you've got any technical questions about sound and things like that, use the chat for that, and Julie will try and answer any of those particular issues. Okay, so questions can be upvoted in the Q&A session, so you can click on the thumbs up if you want to upvote them, and we'll try and answer as many questions as we possibly can during the session, during the last slide of this webinar, or as we go. The meeting's been recorded. I think you knew that anyway when you signed up to join the webinar, but it's always good to just remind everybody of that. So if we can go on to the next slide, we can do some introductions and get going with our webinar. So let me introduce you to some people that you should be able to see on the screen. probably on your top right or at the bottom of the screen there. So we've got some great people on our panel today to respond to your questions. First of all, we've got Dr. Rajesh Sivaprakasan. He's a consultant in renal transplant and dialysis access. He's a lead for robotic renal failure, which sounds like a whole nother webinar actually, at Barts Hospital. So welcome and thank you, Rajesh, for joining us.
Thank you.
We've also got Lisa Banap, who many of you will have heard of. She's consultant nurse in living kidney donation at transplantation at Guy's. She's also the clinical lead for living donation at NHS Blood and Transplant, and she's the vice president of the British Transplant Society. All of our colleagues are many more things than this, but there's only so much space on the slides. So welcome, Lisa. Thank you for joining us. We've also got Dr. Rebecca Suckling, who you will see later on. So she's a kidney doctor, an associate medical director for transformation at Epsom and St Helier Hospital, and she'll be helping us by answering some of your questions in the Q&A as well. So an invaluable team. Also supporting us, we've got Julie, who is somewhere down here as Julie Technical Help. So Julie's from the Renal Association, and she's helping us with that side of things. And then from us at Kidney Care UK, we've got Sharon, who's doing the comms and will be doing a little bit of tweeting as we go through and other such stuff. Myself, I'm policy director for the charity, and Sam Sharp, who is in our policy team, a policy officer from the charity. So before I go into it, I should just introduce myself a little bit more. So I'm the policy director for the charity, but I'm also a kidney patient. After 5 years of dialysis, I was fortunate enough to receive a living donation from my husband, Keith, and that was nearly 14 years ago. So delighted that we're able to be together today to have this conversation. So let's get into some of the questions then. So if we could go on to the next slide, please. As I said, we had loads of questions from people, and they range from risks for people who have kidney transplants. What are the symptoms and outcomes for people with transplants from Covid-19? And then a lot about individual risk and what's the risk to you. So we're going to be pulling that out and having a bit of a discussion on that. Should I have a transplant in the time of Covid? What's the impact of Covid on transplant services and the waiting list? What do I do about shielding? How do I keep safe? And then questions about, children going back to school or at school. What's going on with that? Is that safe too? And lots of questions about returning to work. And then finally, some questions about vaccines as well. So hopefully we'll be able to address all of those as we go through. So next, please. Thank you very much. So what I'm going to do is to open up the session, then we're going to we've put some together as some general risks for people with kidney transplants. So I'm going to ask Rajesh to kick off and talk about the sort of risks that COVID poses for people with kidney transplants, what they might be to those like me. I've got particular interest in this one as well. So Rajesh, could you kick us off, please, with some responses to that? Thanks.
Sure, Fiona. It's a pleasure to be here, joining all of you in this webinar, and it's great to see so many of our patients registering to participate in this activity. I think it is timely that we talk about this because COVID has challenged us in many ways, which than what we anticipated because of the unknown element of the virus itself, and also the fact that we started learning about the virus as we were dealing with the problems across the country. But what I'm very proud of is that the resilience of the people who had COVID and the family members, that includes our transplant patients, and also as an organization, NHS and rest of the bodies, we were resilient in dealing with the problem as we went along. So when one looks at the risks of COVID to a transplant patient, there's two ways we need to look at this. One is to see what are the chances of a person catching a COVID virus infection, and also what are the chances of a person who dies or becomes seriously ill from the COVID infection itself. As I mentioned about the fact that this is a virus which we are getting more and more familiar and learning more about it, we looked at a large data of from all the patients in England who had transplant of all types of organs, and also patients who are on the waiting list. So therefore, we get to see what are the chances of people catching COVID. So what we found was that people who had solid organ transplant, who are advised to shield by the government, their chances of catching COVID is actually lesser in comparison to people who are on the waiting list. And I think the reason why this difference is people who are on the waiting list, they do have to go for dialysis. They do have to leave the shielding what they were advised to do. So we think that is one of the reasons why their risk of catching COVID is higher than somebody who had a transplant with a functioning organ. Therefore, they didn't have to expose themselves to that risk. Now, when we look at the actual chances of a person catching COVID in people who are on the waiting list, obviously their risk is around 3.8%. So that is roughly around 4 out of 100 people who can catch the risk. Whereas people who have transplant and living with a functioning organ, their risk is around 1 to 2%. But this is the chance of any people who can catch COVID infection. Now, the other side of that is people who catch COVID infection and become seriously unwell to the point of resulting in death. There, the risk of a person who had a transplant, their chance of dying is higher. So therefore, because of the immunosuppression and other factors involved, so therefore, the risk of a person dying after transplant, if they catch COVID, is around 25%. I mean, when we looked at when this information was looked through, we were still collecting more and more information. So therefore, in a broader way, the chances of a person who's on the waiting list catching an infection is around 4%. On people who have organ transplantation is around 1 to 2%. And if a person were to get a serious COVID infection, their chance of dying is higher. I hope that sort of gives a broader perspective of what the COVID risks are to people. And I expect we will go into this more detail in the sort of the rest of the webinar.
Thank you, Rajesh. Can you just perhaps bring that out a little bit more about how the risk might differ between somebody who's newly transplanted and someone who's had a transplant for a long time? Any particular differences there?
Yeah, it certainly is. Because what happens when we do the transplant is in the early period, they are on higher level of anti-rejection medications. So therefore, a person is more immunosuppressed in the first few months after transplantation. And also, if a person were to get a rejection, they will be needing more anti-rejection medicine for a short period of time. So therefore, people who are at higher risk are people who had transplant in the first 3 months following transplant, and also people who have had an episode of rejection, which needed short-term increase in their anti-rejection medicines. There are certainly other factors which puts one at a higher risk. That is to do whether it is an early or late transplant. That has got to do with the other comorbidities or other risk factors, such as a person's age, whether they have diabetes, whether they have any other cardiovascular problems, and whether they are from ethnic minority origin. So therefore, there's certainly other factors contributes to it, but the time itself, less than 3 months or 3 months after from the time of transplant, they're certainly at an increased risk of catching COVID.
Okay, thank you. We just click on another slide, please, Julie. So now there are some things that we can all do, whether we are shielding. I know shielding is finished now, but there are some things that we can all do to reduce our risk. And I wonder if you could just briefly comment on those as well, please, Rajesh.
I think reducing the risk is probably the most important thing what we all can do. And things what the government, I think the important thing is to adhere to what the current government advises. What we can do ourselves by protecting us is by washing our hands, maintaining a safe distance, wearing a mask when we are in the public spaces. And certainly, a person who's been advised to shield, it can be of concern in whether any other measures they can take. And what I would suggest is to follow the government advice in reducing the risk. and also minimize the contact of the family members, which we will talk about later, that so that therefore the risks from other members around them can be reduced as well. Now, people might have noticed that these advices does change over a period of time as we learn more about it. But if we follow the government's up-to-date advice and the information provided by the Kidney Care UK website and other organizations, that is the best way to keep the risk reduced to one.
Thank you. That's very sensible advice indeed. And Lisa, have you got anything you'd like to add to that? Are you happy?
I think no, that's extremely sensible advice, and actually it is all down to the individual and following the government advice, because that is, however frequently it changes, that is the advice that we all have to follow. I think there should be a distinction here about young people, because children and young people do not appear to be so susceptible to this virus, and their outcomes in transplantation and on the waiting list are very good indeed, and they have excellent outcomes. So I know some of you asked questions about age, in particular relating to children and young people, or even sort of a young adult. And again, it's all about discussing your individual risk, and the Association of Paediatric Nephrologists has brought out a very helpful infographic to talk about those issues with children as well. But just bear in mind that children and young people do not seem to be so badly affected, and that may really be a very important sort of consideration when you're thinking about transplantation.
Lovely, thank you very much. And we'll look at that in a little more detail in just 1 or 2 minutes, so great. Okay, Julie, could you next please? So what we're going to do is, once we've opened out, we've started talking about the environment, the things we can do to help ourselves, and started to respond to some of the questions that you asked. So symptoms and outcomes. Rajesh, are there any specific symptoms? We had a few questions about that, that people with transplants might experience if they have COVID. Now we have a reduced immune system. So would we actually notice high temperatures and other sorts of things at the same time as people who don't have a transplant? And so anything you can tell us about how we might experience COVID?
Yeah, I mean, the symptoms in general is very similar to what a government advises to look out for. Things such as fever, cough, lack of smell, or any other symptoms. Now, specifically with regards to transplant patients, they can have any of these symptoms, but what I would suggest is a level of alert for any concerns they may have. I think that is what I would suggest that people look out for. If they are worried about it, if there's any change to their health, instead of waiting for one of those prescribed symptoms to be there, if they even have a simple flu-like symptoms, which often people can overlook it, I would suggest that they talk to the clinical teams. It is simply because we are still understanding about the way transplant patients can present with these infections. We have got a good understanding of it, but still, what we recommend is that any concerns they may have, they don't need to wait for all the symptoms. If they have a fever or any other family members who have had any symptoms, it's worth alerting the clinical team and talking to them.
Thank you. Sorry, I was going to say, and I assume the advice there is don't just go up to your transplant unit, ring them up.
Exactly. I think that's what I was just about to say, which is that I think with COVID, a lot of the units have worked hard to provide remote support to their patients. Each of us have our own way of offering that support. So therefore, I would recommend that instead of leaving the shielding, what a person has been doing, it's worth using that approach, whether it's an email or a phone call, before stepping out of the shielding. So yes, definitely get advice before leaving the shielding.
Indeed. Although, of course, we need to talk about shielding a bit later, because as we know, shielding has been paused. So in most of the country, we are advised that we don't actually need to shield anymore. I know we'll talk about that a little bit later if people are looking at this and thinking, oh, but I'm not shielding anymore. So we will absolutely get onto that. Now, I think you've talked a little bit already about the sort of some of the numbers of people likely to actually acquire COVID in the community. Do we know anything more now? Shielding has finished. It's probably too soon to know if the numbers of people with transplants have started to acquire more COVID, or is it too soon to say because it was only last month?
And I think, I mean, it's a bit early to know, but then saying that, I think, I touched upon the fact that how resilient we were as our patients and the families and as an organization is that we never stopped the transplant program across all centers in the country, even at the peak of the COVID. There were centers choose to close their centers based on the local issues associated with it. So therefore, there were transplants performed all the way through, and I'm delighted to say that the numbers are fully increasing across all kidney transplant centers. But what we recognize now is that because of the stringent process of making sure that our patients are safe during this process, we haven't really had significant number of people, or I mean, I haven't even come across any notable number of patients who developed COVID after transplantation. So therefore, what we learned is from the early experience of people who had transplant and lived sort of beyond 3 months and beyond, people with working kidney or other organ transplant, where they are at an increased risk of sort of catching infection or sort of having serious illness from COVID. But since we sort of all the programs have restarted, we haven't really seen much cases. But then it is something to look to learn, over a period of time. We will certainly look at the information again, because all the units are working together to share the information with British Transplantation Society and NHSBT. So therefore, there is more to learn from this, but certainly I think we haven't really seen any big raise in the sort of change to the risk of people dying from COVID.
Okay, thank you. And I wonder if you could just a little bit more on that, because a couple of people have said, are there some positive stories of people who've had COVID, who've survived, done okay? And yeah, another question about very much the same, about people who, people are worried, and they just want to know that there are quite a few people who have had it and who have done okay. And I know that we have a story on our website of a chap called Ethan, who's kindly come forward and shared his story. But I wonder if there's anything you can say about that as well to encourage our audience.
Yes, definitely. I think this is where we all need to talk to each other and assure each other between transplant teams and between patients. I mean, we welcome patients allowing us to share their experience. And what I can say is that in my unit, where people who have had COVID, they recovered from it, and we have placed them on the waiting list. There are patients who had functioning kidney transplant, had COVID, and recovered fully from it, with not a significant amount of permanent sort of effect on the kidney. They had a temporary effect on the kidney, but not a permanent damage to the kidney function itself. So therefore, I think certainly there is a good number of positive stories to share with. And also, I think it's important that we continue to share this information to assure our patients who are on the waiting list, so that they can come forward when the opportunity arises.
Thank you. And I'm sure that's one of the reasons that people are on the call today, to hear about some of that and hear a bit more about it. So that's positive. Thank you. Now, I think we need to come on now and start to talk about understanding our individual risk. We've alluded to this several times, and we had a lot of questions about that. And some of these were very much age related. So I wonder if we could just go on to the next slide, please, Julie. And that's okay. And what I'd like to do is, Lisa referred to it a little bit earlier, but we've had some sort of various questions from people in their early 30s about like to understand their risk, what happens to them. Will young transplant patients be included if we had to shield again? Are younger transplant patients at lower risk of dying? What percentage of young people have had a kidney transplant and become unwell? So there's a range of questions there on that similar topic. So I wonder, Lisa, if you could comment a bit about on the current situation. And sorry, apologies to someone who said that you can't read the slide. Yeah, sorry, it's not great reproduction. This is all on our website, on the Kidney Care UK coronavirus website as well. So over to you, Lisa.
So I think this is the hardest part, isn't it? Actually understanding what this means for you. And it's all very well us talking about information and data that we collect, but actually but if I'm making that decision here and now, and I think we're going to talk about this a little bit more in some more detail, but I think it will depend very much upon, we've talked about age, but all those other confounding factors like your ethnicity, what kind of treatment you're on, and I don't want to cover that ground just now, because we will go into more detail and answer some of your immediate questions. This infographic that you can see here, and it is a little bit difficult to read, but but actually gives you a flavour of the kind of thing that we're using as a decision-making aid when we're sitting in a clinic talking to people. These are constantly updated because actually, as Rajesh has already said, the information changes. So what we knew at the beginning of the last wave of COVID will inevitably change as time goes on and we collect more information. And there's 2 registries, one within the renal registry and one within the NHS Blood and Transplant Registry that's collecting and analysing this data all of the time and comparing it with the countrywide data. But this is a kind of example. So you can see it's quite a simple sort of infographic based on a red, amber, green kind of thing. So looking at where's my greatest risk. So if I'm in the immediate transplant period, and I'm struggling to read this actually as well, but you get the idea of it. And then the things that might make you at less risk, and the things that in particular waiting for a kidney transplant as a younger person, your risk is actually much lower. And in fact, for many weeks and over the last part of the pandemic, our paediatric colleagues were taking children out of shielding because actually their risk was seen to be very low. I'm happy to take more questions on the infographic, but the principle here is that it gives you an ability to talk about the individual circumstances and to relate that to where they are now and what their aspiration is for a transplant, and then have a conversation based upon that individual. I hope that answers your question.
Thank you, Lisa. And I think there's a few questions that have come up, but I think they probably apply particularly to Rajesh, because I know you quoted a figure, Rajesh, which was very much an average figure about people, the sort of risk of mortality, and a lot of people have focused in on that. So I wonder if we could take that out a little bit, because clearly an average figure is an average figure based on not very many people at all who actually had COVID and had transplants. And I wonder if you could put that into context. And then if Julie could click on the next slide, we're going to look at a little bit more of an infographic, which looks at people who are a bit older and talked about what those risks might be in the different sort of by ethnicity, by age, and so forth as well. So I wonder if you could just address both the overall numbers of people who've actually had COVID with a transplant, which isn't very high, and therefore how accurate that number is, and then where that differs in terms, because Lisa's already explained it very well from the point of view of children, but for others as well. Thanks.
Yeah, sure, Fiona. I think it's important to remember that these are information based on small amount of cases what we had. So therefore, when it comes to risk itself, it is individualized, and the infographics what we have in front of us, and also the information what we use to make decisions, is very much on the for individualized to patient themselves. So first thing, on a broader perspective, I will advise anybody who wants to know what it is to talk to their teams, because what they can tell them is they can put this into more direct perspective with all other clinical issues with that person. So that's the thing I would recommend to them. But going into the details of the risk factors itself, we can, the risk of somebody becoming higher risk in catching COVID includes few factors. One is age of the person. If you look at the bottom of the screen, if people can see, the one on the red, what it says is high risk for sort of COVID-related problems, is it says that it's age of the person, their diabetic control, and the age is more than the age of 60, their obesity, their kidney function, which is their kidney function is they're on low enough that they're on dialysis. So therefore, these patients are what we would call as a higher risk patients. Now, what this means is that they need to be sort of a lot more careful in the way they look after themselves with regards to how they make decisions. And this is where the clinical teams will guide them to have the appropriate advice on how to pursue a kidney transplant. And also people who have had transplant coming into this group, which is again the higher age, diabetes, and other cardiovascular issues, they need to be a lot more careful. There's one other group where I touched upon earlier, is people who have had transplant and they're within the first 3 months of from the transplant. So therefore, they also on the higher level of anti-rejection medicines. So therefore, they also become higher risk to acquire problems, mainly such as COVID. So therefore, they become higher risk patients. Now, what this means is that they need to adhere to what the government policies are in following all the advice. And also the clinical teams will guide them through how to be careful with the medications and all the other support what they need. And I hope that sort of gives you a broad perspective of how the age and the other comorbidities of the person qualifies them about whether they're higher risk or intermediate risk or lower risk.
Thank you, Rajesh. There is a further question that you hinted at earlier and has come up in the questions as well. So it's people who are from the BME communities. So what evidence do we have of any additional risk or mitigation in there? And perhaps you could just talk about that in a little bit more detail. It's come up for a couple of people actually.
Yes,
Great.
I mean, I think this is, I mean, I think the people of ethnic minority origin in general population, there is enough data to suggest that they are at increased risk of catching COVID and having severe complications from COVID. Now, we don't understand all the, we think it is multifactorial. It is not one element of it. And at the moment, we don't fully understand why that the ethnic population, particularly black and African origin and certain types of Asian origin, they seems to be at a higher risk of acquiring COVID. But then the transplant population, they're also another risk factor. So therefore, if you're ethnic minority origin, learning from the general population, we find that they are at a higher risk of catching COVID as well. Although we don't have a full understanding of why they're at more higher risk than a Caucasian population.
Sorry, I was on mute, which is that terrible mistake everybody makes at least once during these things. So is there any particular evidence that if people do get COVID and go into hospital and they're from the BME community, that they do any worse or the same as people who are not from a different community?
I mean, what we learned from the general population without a transplant, what we learned is that they do seems to be doing worse, that the outcomes are far more worse in comparison to Caucasian population. And I think that is something we are continuing to investigate to see why they have, whether there is any clinical issues or whether any other factors. So at the moment, it's difficult to be very clear about why they have more complications or their risk of dying is higher than a Caucasian population. At the moment, it's very difficult to be very clear about it.
Okay, thank you. And a couple of other questions. People say, is 43 young or old in this? So I know we've got under 50 and over 50. So I forget who asked that question now, but you know who you are. So,
I think what I would suggest is that, I mean, obviously this is where I think, as Lisa was touching upon, that individualizing yourself. I mean, all these infographics and information is a guide, but when it comes to it for yourself, I think we would suggest that please talk to your teams so that they will personalize the risk for you, and also they will offer you the appropriate advice. Because this is a conversation we need to continue to have. And it is not going to be one consultation where everything is being offered. And also with ever-changing times with the COVID and the advice from the government, I think it's important that it should be an ongoing conversation. So therefore, you know what your risks are, what group you come under, and also what sort of support you have with your teams, and also what you can do to reduce your risk. So it is an ongoing conversation one need to consider with their teams.
And thank you. And in response to another question, is it reasonable to say that actually the sort of mortality levels that you talked about are really for people who would perhaps be older or have more of those comorbidities? So again, they're very much an average, but what we've seen so far in line with the rest of the population, unfortunately, does focus on people who are slightly older, people who have more things wrong with them.
I think, yes. I mean, the factors what we quote is from what we learned in the early period, in the initial sort of from February to May. So therefore, the two things have changed. One is obviously the way we look after our patients have changed, particularly our transplantation patients have changed significantly. And secondly, there were a lot of advice now about reducing the risks, which all our patients are following it very carefully. So therefore, what will be quite interesting is to see in about 6 months to a year's time, because since all the units have started transplanting, we haven't seen many number of people having COVID following transplant. So therefore, what the data suggests is from the patients who were transplanted before. And because since we started transplanting again, we haven't had many cases. It may be that what the current practice of how we take people through transplantation and looking after them after transplantation is offering opportunities to keep their risk significantly lower. But that is only we can look at it over a period of time.
Right. Okay. And then I just think there's probably one more question in here. I mean, there's loads of questions, and some we'll come on to later on as well. Just as to whether you have any further data on perhaps loss of, rather than people actually, the mortality figure, which I know people are discussing quite a lot here, but also on the sort of risk of losing your transplant through COVID. And I wonder if you may not have information on that, but if you do, in fact, either of you, please do comment there before we move on to our next.
I mean, at the moment, I think I don't have the data presently with us, but certainly it is something, I mean, what we can certainly provide at some point later, because at the moment we don't have that kind of data to see how many people actually lost their kidney function. Now, saying that, in the data, what I was telling you earlier, that the data reviewed between February and May, which sort of helps us to identify the risk factors and also identify the risks of catching COVID, people do lose their kidney function after COVID. That is because of the overall impact of COVID on the body, COVID infection on the body. And majority of them who recovered, they do recover kidney function. But it's difficult to say at the moment categorically what kind of impact they will have once they fully recovered. It's difficult to say at the moment.
Okay, thank you. And there's one more question just to ask from here, which is about will individual letters be issued to patients highlighting the level of their vulnerability to COVID? And I think I know the answer to that, but I'd like you to comment, which is, I think, it's available to people if they ask for employers, but that would be for you to comment as well. Because
yes, and I think this is one of the challenges people did find early on. There were a lot of variations in the way how the teams were supporting them. I mean, what I do suggest is people talk to their local teams. They will have access to a letter summarizing their clinical issues. So therefore, they all can get access to their clinical letters about their current status, their kidney functions, all their test results, and so on. And also there is, I think Kidney Care UK has worked harder to get the sort of a template letter, which is available at the moment, which can be used. With regards to individualized letters for their employers, I think it is a conversation we would recommend that they have there with their own clinical teams about what they can get. But what I do notice is that there's certainly interest from all the clinical teams to offer that support to their patients.
lovely, thank you. And it's the Renal Association, I think, who
Yes.
pulled together that letter. We've made it available on our website. So thank you. Now, there's a lot of questions. Someone's raised their hands as well. Please, can you put the questions in the Q&A, not the chat? That's where I'm looking, and that's where Becky will be looking as well to give you some of the responses on there. So that's just for everybody listening here. So what we're going to do is, Julie, could you just click next, please? And so we have quite a key question here, which kind of relates to everything we've said so far. And it's really, should I actually have a transplant now, given all the things that we've just talked about? And what I'd like to do is ask Becky, Dr. Rebecca Suckling, just to come and just join us for a minute or two, just to talk about, from the point of view of, is home dialysis better or not than having a transplant? Can you please give us an opinion on that as a kidney doctor, please? So Becky, I don't know if you can
Hi.
unmute yourself. Thank you very much.
Hello. Firstly, sorry to everyone, I'm typing as fast as I can, but there are lots of questions coming through, and I'm saving some of them for the live panel, but I'll keep answering as quickly as I can typing wise. I think one of the questions that is coming through is, should I have a transplant now? And it is an individual risk-based decision, and what I would consider if I was your kidney doctor is what is your personal risk? If you're a satellite dialysis patient who has to come in to dialysis 3 times a week, who's been on the list for a long time, who is offered a kidney and is younger, then I think there is no reason why you shouldn't go forward for a kidney transplant. And I'd feel very confident in recommending that because of all of the infection control processes that are accompanied with it. I think that if you're someone who is dialysing at home and is able to self-isolate, which can be challenging, and now the government support for people who are self-isolating is no longer there, but you're and you're very stable on dialysis, you may want to look at what your current part of the country is like in terms of COVID-19. Are there a lot of current cases? Do you want to take that risk at this moment? Do you want to wait a little bit longer to see if the prevalence comes down a bit? So I think it does depend very much on your own circumstances, and it's worth going through this in detail with your physician, your doctor that looks after you, so that you can work out between you what you think is the right thing for you. And again, it's about whether, if you've got a live donor, I think that's a really safe process now, and I would feel that quite confident that you would be able to manage that and in a relatively safe way. If you're going, equally, if you're self-isolating and you have a transplant that's from a deceased donor, a lot of things are in place and we could do rapid turnaround COVID tests to see if you're carrying COVID at the time of surgery. So I suppose there isn't a right or wrong answer. It's the answer that's right for you at the time that is important. It would be my view.
Thank you so much, Becky. Thank you very much indeed. That's really helpful just to open up this session and kind of put it into context for everybody. So I hope the questions are coming through, but people will feel that's a helpful, very helpful set of comments. And what I'd like to do now is I'd like to move on then and just to this whole question about, is it a good idea to get a transplant at the moment? So Rajesh, I'd like to ask you to explain what will happen if you're called in for a transplant to keep you safe. And if you could just briefly take people through that. You get the call, sure. What happens next?
Yes, I think, I think all the units have worked harder to make sure that we can offer the confidence to the patients when they're called in for a transplant. And so therefore, a lot of the units will update the patients who are on the waiting list to say that these are the current processes. But regardless of that, on the night or whenever they get a call, the first thing is they'll be explained about what is going to happen, because the hospitals are divided into different zones. Some zones are without any COVID patients. So therefore, our patients will be recommended to come through that pathway, that entrance. That in my hospital, that includes separate lifts to come to our floors. They will be admitted in the area where there are no COVID patients, and they will stay in the same area after the transplantation. They'll be tested for COVID to make sure that they don't have COVID. And if they have a COVID, we don't proceed to transplant. So therefore, there's a lot of steps taken before a person actually has the procedure. As a country, we do not use organs from deceased donors who have COVID or has higher chance of having COVID. So therefore, we do not transplant organs from people who die because of a clinical problem. And during surgery, obviously, we take all the steps to make sure that if they need to be having all the personal protections, in a non-COVID environment, we still use some layers of personal protection. So therefore, those measures are taken through when the person goes to sleep, when the transplant is performed, and when they come back to the ward. And there is a very close sort of way we look after them, in the sense that there is very limited number of people who we look after patients. Therefore, instead of a large team looking after the same person, we restrict the number of people who care for the patient, transplant patient after procedure. So therefore, the chances of them catching any risk of catching COVID in the hospital is kept as little as possible. And after discharge, there is the whole follow-up of patients following transplant is a sort of planned per patient. So therefore, they have to come face-to-face clinic for once or twice a week. There is a lot of remote follow-ups have been arranged. So therefore, they can come in for blood tests and have video appointments. So therefore, the units have made sure that before the transplant, we can keep them safe, make sure that they don't have COVID. During their hospital stay, make sure that all the steps are taken so that the chances of them catching any chance of COVID is kept as less as possible. And also, we look after them following transplant with very minimal chances of them acquiring COVID. So these steps are all in place when many of the units restarted the program. That is in the context of a deceased donor transplantation. With regards to live donor, as Becky said, it is certainly a planned procedure. So therefore, it makes it even more safer. So one can plan the procedure and come through with what I would call as a non-COVID pathway. So therefore, their risks are even more lesser. So the question of should a person have a transplant at the moment? I think it is it can be a very stressful decision to make on the time when they get a call. But I recommend that people do talk to the clinical teams so that they can understand the processes, what is in place in their hospital. So therefore, they can be assured that they can go through the process without having significantly increased risk of catching COVID. Few of my patients whom I transplanted very recently, they felt that they observed the care what is offered, and they've sort of felt reassured all the way through that the steps in place are protecting them. The only challenge one of them mentioned was that they couldn't see the family members as they would like to see. So that is the only thing often people find it difficult, that the family members can't come and visit them as in normal times they will do. But apart from that, the clinical care and the safety of a person going through the process of transplantation across the country, I can say confidently, is definitely assures all the patients who had transplantation. Therefore, certainly one should consider it. And if they are worried about it, there is no harm in talking to the clinical teams about what their concerns are, so they can be assured that there are processes in place to keep them safe.
Thank you. I had some really caring and well-considered processes and suggestions there, Rajesh. What I'd also like to do is just take that on a little bit more, because we've heard how much work and thought has been going on this. But I'd like to ask Lisa if you could comment a little bit about how the transplant community is working together to prevent transmission of COVID, what special measures are in place, what you've learned so far, and what you and your colleagues are doing to help to assure, as best we can, non-transmission of COVID in people who receive transplants. Thanks, Lisa.
Yeah, so Rajesh has detailed really how things are happening, and this is really a sort of a summation of all the learning that we've had over the last few months, and I think really importantly the community has come together to agree in very short time frame actually how we should be running services, what the services should look like, and how we can work together. And I think in particular what I've been impressed about is working in the extended clinical team within NHS Blood and Transplant, where we've met, discussed, produced documents that are useful, hopefully useful for the community, and have revised those documents on a weekly to fortnightly basis as required. So this underpins the whole of our UK practice. So wherever you go in the UK, the same thing should apply, although it might look slightly different because of course your hospital may look different or your service may be different. And as Becky's pointed out, there may be different considerations in the community or even in different countries about how COVID-19 is being managed within the community where you live. But primarily there's a lot of underpinning information and a lot of things in place, and we're learning all the time and we're getting better at it all the time. And the bottom line is that nobody wants you to feel unsafe or be unsafe when you come into hospital. So everything is directed towards you, and if you have a living donor, the living donor. And I think we've moved an enormous step forward in this last period. And I think that if you're thinking about, should I go into hospital now and have a transplant, all the things that Becky has said, all the things that Rajesh has said, I think you can be sure that nobody would invite you into hospital for a transplant if they didn't feel it was safe for you. And that's really what you should take home. And I think the danger is that people feel quite understandably and legitimately really frightened about going into hospitals. It's much, much more important that you come in, particularly if you're unwell, and you tell us if you're unwell, but also that you really think about this very carefully, because it may be a greater risk for you not coming in to have a transplant than it is for you to actually have a transplant. So you just need to really think very carefully about that.
Thank you. And Julie, could you just click on, because I'd just like to stay with Lisa a little bit more here, about if we can just talk a bit more about, the whole impact on the waiting list, how much longer people might have to wait for a transplant because of COVID? Anything particular about living donation, how that perhaps differs from deceased donation as well? And also in this kind of session about what people are likely to be told about whether they're suspended, unsuspended again, or sorry, deactivated, is the technical term. That would be great. Thank you, Lisa.
Okay, so critically what you've heard today is there are lots of generic things that we need to think about, but there are lots of individual things about every patient that are important. And so if you can keep that message in your mind, I think that's absolutely critical. In terms of how long you will have to wait and what's happening in transplantation in general. So what I can tell you is that deceased organ donation recovered extremely quickly, actually. In fact, although it felt as if there were big differences around the country for some time, actually it was a relatively short period of time. But I can imagine if you were a patient living in one of the areas where transplantation wasn't available to you, that it felt very much longer than it actually was, when you could hear about patients in other parts of the country actually receiving transplants. What we would really collectively all want to avoid is that happening again. So all our efforts have gone into services not being closed down, so that wherever you are in the country, you have access to transplantation. Now that's not as easy as it sounds, because it's a massive collective effort and it's beyond the clinical community. It also requires our commissioners to work with us, and we've been working with them to see that what we can do to make sure that happens. In the meantime, the deceased organ donation has pretty much gone back to where it was pre-COVID in terms of the rates of donation, which is a really good thing. Living donation has been more difficult. Living donation stopped in the middle of March, basically, and many of you will have felt the impact of that, I'm sure, if you had a transplant identified in a recent matching run, for example, or if you were waiting for your transplant to be scheduled from your own family donor or friend. That we have had, again, a huge effort to put in to try and work out how we can prevent that happening again. So what I can tell you is where we are now is that all centres are now open to living donor transplantation again, but all patients all over the 4 UK countries have access to living donor transplantation. That the kidney sharing scheme October matching run is set to go ahead to plan. So of course we haven't had a matching run since the beginning of the year, and I know that's been hugely disruptive for everybody who's been involved in that. But we're really hoping to keep that back on schedule, and that's really with the support of all the centres, individual centres, who are really enthusiastic to re-engage with this. I think it came as a huge shock to us that living donation just stopped as well, and we really want to prevent that happening again in future. And so we're working very hard together, as I say, with centres to see whether or not, if donors and recipients, for example, are willing to move to receive a transplant, that we can in some way facilitate that, because that is an option. And if that's something that you're willing to consider, then that's something certainly to introduce into your discussions with your clinical team. So if we got to the position where transplantation isn't available in your particular centre, well, could it be available for you somewhere else? And that's a discussion that I think it would be fair to initiate. And your final point, Fiona, about the waiting list. So it's a little bit difficult to know for certain exactly what's happening to the waiting list at the moment. And the reason for that is that there are still some legitimate restrictions on people on the waiting list. And those are primarily concerns about all the things we've heard about today, the age of people waiting for a transplant, other long-term illnesses or comorbidities, as we call them, that might affect your health and therefore put you at greater risk. And that's what we don't want to do. So there may be some restrictions in waiting lists, so that actually when we look at the actual numbers, it may be a little bit difficult to tell at the moment that the waiting list has gone up or it's gone down because of those. We do see that there are more people waiting on the waiting list for an organ transplant in comparison with before COVID. But we hope that the measures that we put in place will see that balance out over time, and that the impact of COVID will be as mitigated as it possibly can in that regard.
Thank you. And just one other thing on that that's come up about, can you see if, you know, in a situation at the moment where the infection levels are going up, can you see the whole transplant system being closed down again?
Well, what happened before was that NHS Blood and Transplant took the decision that it was up for individual centres to make that decision, because actually the teams, the clinical teams in those hospitals and those hospital trusts were best placed to do that, depending upon what was going on in their local environment. Rajesh may want to comment on this from a very much one centre perspective, but what I'm hoping is that, as I've said, that we don't have closure of programs, but of course, every transplant program sits within a hospital where there are lots of other competing priorities, and it may not always be the wish of the clinical team in the transplant centre that happens, but it may be an imperative within the hospital trust itself, and that's more difficult to influence or to have control over. So I can't put my hand on my heart and say that will not happen. What will not happen is that there will be some central edict to say the whole program needs to close down, because that isn't the way we work, and it isn't the way we intend to work in future. We're very clear about that. But there may be local considerations and restrictions that do put those limitations in place. Rajesh, I don't know whether you want to add to that.
Yeah, sure, Lisa. I think as Lisa was saying, that I think last time what happened was the resources, what was needed to run a transplant program, was diverted to manage the unexpected COVID challenges. But what we have learned in this time is twofold. One is we know how to look after our patients before, during, and after transplant, how to look after their kidney function after transplantation. And secondly, also, the hospitals have learned to how to do other procedures, transplant, cancer operations, heart operations, so on, in a careful manner, also managed with the COVID patients. So therefore, as an organization, we all learned a lot more about how to allocate ourselves to maintain some of the services. So therefore, the question of if the COVID numbers goes up, would it have an impact? I think, certainly there will be impact, but what I would expect and hope is that the impact won't be like what it was before. Because one, the organizations have learned how to do this. The transplant programs have understood the ways how we can look after our patients, and continue to show that in the recent months by successfully delivering transplant services to our patients. And thirdly, I think we can divert our sort of workforce a lot more better, knowing that we can maintain the rest of the services going on. So there may be an impact, but at the same time, certainly we are in a lot stronger position to continue to offer transplant and other clinical procedures what our patient needs.
Brilliant. Thank you very much. Now, time is moving on, and we still have 2 or 3 really important questions to pick up on. And I know we said we would run over by about 5 to 10 minutes if necessary, and that looks like it's going to be necessary. So I hope that's okay with everybody listening and everybody taking part in this. So Julie, could you click next, please? So we need to talk about shielding. There's been quite a few questions that have come through today and on the list there. So we've talked somewhat already about keeping safe and about all the things we can do, and the best tool being keeping your distance. So I think we'll focus on shielding particularly here. And so Rajesh, there's a few things in here really about, should I shield if I'm on the transplant list? Perhaps you could also comment on the sort of the 2 weeks before a living donation, and on the 3 months after a transplant as well. So there's 3 sort of parts to that about whether I should shield. So over to you. Thanks.
Yes, thank you. So I think the question of should a person shield when they're on the waiting list, certainly, we see people who are on the waiting list as higher risk patients of getting COVID-related issues. So therefore, certainly as much as they can, because if they're on dialysis, certainly they'll be visiting the hospitals 3 times a week for hemodialysis. So therefore, certainly we do recommend that they shield. With regards to transplant itself, I think how they can keep themselves safe. Is there the second question? Sorry, I missed the second part of the question.
So the first one was shielding if you're on the transplant list. Now shielding has finished. But the second one was very particularly about if you know you have a living donation. I believe perhaps you could confirm the advice there. And then thirdly is post-transplant.
Yes, sorry, definitely yes. So once a person is identified to have a matched or a suitable living donor, certainly we recommend that the donor and the recipient, they shield for 2 weeks before the procedure. In the 2 weeks, what we do is we do their COVID tests as well. So therefore, what happens is in the 2 weeks, we certainly want them to sort of shield for 2 weeks, and then they come for the procedure. And after the procedure, all the transplant patients, we do recommend that they stay isolated for 3 months. Now, certainly, I think based on the government advice and how things are in the future, things might change. But currently, what we recommend is that 2 weeks before live donation, we do recommend them that they shield before that procedure.
And after a transplant, the same?
Yeah. Yes, indeed. Yes. I think the question was after the transplant, it's the same. Yes. 3 months.
Yeah. So, but for 3 months, as people
Yes,
have.
indeed, yeah.
So 3 months is the period that somebody, that whether if you were a donor, a living donor that is, or in any case if you were a recipient.
No, I think I just want to make it clear that it is for the recipient. It is the isolation period is 3 months. For the donor, once they donate it and they recover following the surgery, they shouldn't need to isolate a longer period of time.
Thank you very much for that clarity. Yeah. Thank you. Julie, next please. So we've had lots of questions about going to work and going to school. So the first one is just about, is it safe for people to return to school? And there's been a lot of discussion about that. And so I don't know whether even Becky might want to respond to this one actually. So is it safe for children, or no, sorry, Lisa, because Lisa, you were speaking about this earlier. Is it safe for the children of kidney patients to return to school, and what can be done to reduce the risk of doing so?
I think this is quite a difficult question, and it's not just about parents, it's also about school teachers, and we've got lots of questions in the chat around this. What we're finding out is that the primary school age group seem to spread COVID-19 less and are thought to be less of a risk factor. But at school now, people are getting very familiar with the terms of bubbles, and school keeping children in bubbles to try and reduce the risk of spread between the school. There is a certain risk to going to school for in terms of your child picking up COVID, but the school should be ensuring that they reduce that risk with hygiene, with bubbles, with all of these factors to try and mitigate it. And it is thought that actually that it is a relatively safe thing to do. In terms of teaching, I think that's a slightly different question, and I would advise that you ensure that you've had an adequate risk assessment at work, that if you need support from your renal team in terms of helping you them understand why your risks may be higher. And we also have advocates at Kidney Care UK who can also help, and considering if you're a member of a union, having a chat with your union to try and ensure that you can reduce the risk as much as possible. Or a lot of the the emphasis really is around making sure that you're safe to be at work, and that is your employer's responsibility.
Brilliant, thank you. And actually, Julie, if you could click next again, that nicely feeds into the next set of questions. And we have had so many questions from people about being safe to go back to work, and we've had a enormous number from patients in particular, from teachers in particular, both primary and secondary school. Some people have had, who are asking about those bubbles. Is it safe to teach? What can we do, because it's not easy to socially distance. And I think, Becky, you touched on some very important things there, which is your right to have an occupational health assessment. The fact that on the Kidney Care website, which we'll be sharing again in a minute, there are some hints and tips for people who are being asked to go back to work and what to consider now. Actually, the fact that the government just last week then said that actually if people can work from home, they should be encouraged to do so, which is a slight change in the previous advice from the government. So there's a lot in there about returning to work. But it's not just teachers, of course. There are many other people who are in frontline types of jobs as well, where they may have contact with the public. And I wonder, Rajesh, could you just make a couple of comments in here as well, if possible, about whether it's safe to return to work, particularly in those public-facing type roles?
Yes, I mean, I can see that, as Becky said, it can be very stressful for one to take the responsibility fully onto themselves in making these decisions. So therefore, it's the employers who has to offer them a risk assessment of what their risks are and how they can accommodate support for them locally, so they can be at work to, if they don't have the choice of working from home. And secondly, they can request the clinical information from their teams, so that when they have the discussions, if their occupational health can't provide adequate support, or because they may not have an expertise, the clinical teams can offer their information of what their current health is, what their recommendations are with regards to their transplant care. So they can pass the information to their occupational health. So therefore, they can make a better risk assessment of the person. Now, certainly, I teach in the medical school, and what we found was that we do have to find a way to keep us safe, and our patients or teachers safe, or any other public-facing roles, and also the students safe as well. So there are a lot of ways the working environments have changed. A lot of remote educations have come through now. So therefore, I think certainly it is the conversation, instead of a person trying to find their own solution, to ask their employers to offer their appropriate risk assessment and the support to see whether they can continue to work from home, as the government suggested from last week, or any other way where they can be kept safe. So therefore, I think the safety has to be maintained for a person to be advised to go for a work in a workplace environment.
Okay, thank you. And that is very much your kidney doctors, your transplant doctors are there, and your whole team is there to support you with that.
Yeah.
There's a further question actually that's quite a bit today and previously about family members. What should family members do when they have people in their family who have a transplant, have recently had a transplant, or have had one a while ago? What care should they be taking when they go to work and they're out and about? So
I think the advice need to be very similar to the lines of reducing the risks. I think one need to look at how they can reduce the risk. That we can't stop somebody living with the family members and ask them to go and live somewhere else. So therefore, so it's really looking at what the government advice is, how stringent they can be in following the sort of washing hands, keeping sort of wearing masks, and using those sort of chances to reduce the risk. And the third thing to remember is that if there's any concerns they have that they may have any symptoms, to get themselves reviewed, talk to the clinical teams. So therefore, it's really making sure that they take the steps in keeping the risk as less as possible, and also suggest to the family members that they sort of keep the communication of whether any change to their health or the patient's health. The patients can talk to the clinical teams together. This is what has happened. What do I do? And what the clinical teams can offer advice based on what they hear from the family members' symptoms is to say they might sort of give appropriate guidance for the person.
Lovely. Thank you. Thank you. There's some very sage advice in there. And Julie, could you click next slide, please? So we're coming to the end of the main section. We'll probably use another 5 minutes shortly just to pick up on any other immediate questions that we can address. So Rajesh, just on the important topic of vaccines, we had some questions through about the COVID vaccine, or COVID vaccines, when they perhaps might get here. So just a few things about what you think about is the likelihood of a vaccine coming up. Will it be any good? Will it be any good for kidney patients? And then perhaps just a quick comment, because it's really important, about the flu vaccine as well. And then we'll open it up for the last 5 minutes.
Yes, I mean, I think before going into the COVID vaccine, I want to emphasize the fact that all our patients need to consider getting the flu vaccine at the earliest opportunity. I think it's important that they have the flu vaccine instead of waiting for the COVID vaccine. Now, with regards to COVID vaccine itself, there is so much information. I'm sure people might have come across in the media about the different teams working on the COVID vaccines. We don't have enough information to say what will be successful, which one will be used, and how that will be given across all patients. And so therefore, at the moment, on the sort of COVID vaccines, we hope that there will be a vaccine available as soon as possible. Certainly, our patients will be coming under the high-risk group, so therefore I would hope that they will be considered as a priority group. But certainly, we don't know enough at the moment to say when it is going to be there, how successful it is going to be, and how much protection it is going to offer. But what I would suggest is that people to just contact their local teams to make sure that they are vaccinated the flu vaccine is at least given to them at the moment. Yeah.
Just quickly on the flu jab, somebody has asked, yes, can we arrange it ourselves in a pharmacy? And the answer to that is yes, or your GP will do it. Yes, and there's no need, as far as I know, but you tell me, because I'm definitely not a doctor, to have a booster jab for the flu vaccine. It's just a one-off, is it?
Yes.
Yeah. Okay, that's fine. Great. So, Julie, could you just click? This is where, just to remind everybody that that's the website where those various infographics are on. Sorry, they weren't fantastically, didn't reproduce great on the screen there, but they're all in there. That information is updated every single day. We talked about the social distancing being one of the most important tools we have available to us to help us. And some of you may have seen that we're supporting this Distance Aware campaign as well, so that's why that's up on there. Now, there are a few questions here that we may be able to touch on, but we won't be able to touch on all of them because they keep on coming. So what we are going to do is we will be writing up a report from this. We'll try to address any of the unanswered questions. If you had individual questions, I think, as we said at the beginning, that still is a conversation for you and your renal teams as well. There are various support things available for you, and we'll refresh on those in a moment. But just to say, okay, so let's have a look through here. Yes, I think we've talked about the donors, haven't we? And we've said that donors, once they've donated, once they've got better, they don't need to keep on shielding like somebody who's just had a transplant. We talked about that. A question came up about acute kidney injury, Rajesh. That's something that you mentioned earlier about the particular risk of the kidney from COVID-19. And I don't know if there's anything that you can comment on in general about that. I mean, we know it's a new risk, isn't it, to a kidney? So is there anything to say about that?
No, it is in the context of their overall health being compromised. That is what seems to lead to acute kidney injury in a transplant person. But what we don't have enough information to see whether they have any long-term impact from it, we don't have that information at the moment. It's really the overall impact on one's health seems to compromise the kidney function. But the people who recovered, many of them didn't really lose any permanent sort of dysfunction to their kidneys.
Okay, that's really helpful. Yeah. Just on the flu vaccine, can we be clear? Is it the live vaccine or the non-live vaccine? So that people with transplants should be having.
So it's a non-live vaccine. That's what for the adults. So that's what they will need to have for them. Yes.
Okay. And for children?
Okay. So, hello?
Sorry, for children.
Oh, okay. For children, it will be the nasal spray. They won't be able to have the intramuscular one. They will be having the nasal spray vaccine there for them. Yes.
But is that right? That they have to stay away from their parents who may have a transplant in that instance?
Yes, indeed. So if they have that, for children have that vaccine, then yes, certainly they need to be away from there. Yes, if the parents have transplant, yes.
Okay. All right. And there's quite a lot of questions there about
Fiona.
Sorry,
Fiona, just a quick thing, that if you have a child with a transplant, they shouldn't have the nasal vaccine.
Yeah.
So if you have if your child is having the flu vaccine, which they should, they can have the live vaccine, but make sure that you keep a bit of distance from them. But if you have a child with a kidney transplant, they should not have the nasal vaccine because it is a live vaccine and they shouldn't have it.
Right. Okay. Lovely. Thank you for that clarity. Now, there's a few other questions about transplant clinics, and I wonder if we could just briefly. People are saying, can those clinics be done remotely? Should people be going into their clinics? Do we have a choice as to where we have our blood tests? And I wonder if we could just comment on that. And then there's one other question I want to raise before we close the session. So transplant clinics.
So when a person is discharged, we clearly lay out a plan to them, personalized plan to them, saying how many times they have to come to the hospital. And also they have a very specified time slots as well. And many of the clinics are moved out of the main hospitals. So therefore, a lot of the transplant teams have made arrangements so that the number of times a person is exposed to a main hospital where there are COVID patients is kept as less as possible. So in my unit, they have face-to-face follow-up, which is once a week. And then also they have blood-only visits where they don't even need to come to the hospital. And now we are looking at moving the whole follow-up into a hospital where there are no COVID patients at all. So certainly, I think a patient, I mean, this is where I think before, if a person has a discharge, a transplant, and before discharge, the teams will explain to them how the follow-up is all arranged. If people are anxious about it and they're on the waiting list, it is certainly a conversation worth having with their clinical teams. So they can be assured that there is these are all very clearly defined processes. So therefore, I think they will be able to assure them what is there in their local teams and how they are organized, so that they can be assured as well.
Okay, so it's our choice.
Yeah, certainly.
And it's certainly our conversation to have with people.
Yeah.
Okay, so before I go on to the last slide and just confirm some of the things that we've talked about, is there anything that any of you on the panel here would like to say? You've seen the questions coming through. There's a lot of them. We've addressed many of them, but I know we've not addressed every single one of them. So anything that people feel they absolutely have to say. Lisa, you?
I wanted to make a point about living donors, and what Rajesh says is absolutely right, but just bear in mind that if you are identified in an exchange which involves other donor and recipient pairs, it is worth just thinking about being really careful in that 2-week run up to the date, because if you have been exposed and then you test 2 or 3 days before as positive for COVID and the transplant goes down, it's not just you and your recipient, it's actually you and the whole chain. And that can be quite debilitating. So just really, we probably ask for a little extra caution if you're involved in an exchange, purely because of the impact on everybody else if it falls down. And of course on your own recipient, because they may very well miss out as well. But that's just for your thought, really.
Okay.
I would like to add that it is, I mean, I think for all our patients, when I see them, it has been an extremely challenging time in the last few months. I think COVID has thrown up so many challenges, but what I can assure is that the processes, what has been developed, the information, what is available, please use them. I think so. Understand them more. When you're on the waiting list, please look for these. I mean, the local teams will be able to provide them. There are national organizations such as Renal Association, Kidney Care UK. There is a lot of information there. But at the same time, do talk to the clinical teams to make sure that you are fully happy with what is in place. So therefore, you're not in shock on the night or day when you get called for a deceased donor transplant. And okay. I think certainly this is a process where we are learning, and certainly we want to make sure that everything defined is to make sure that our patients are safe.
Thank you, Rajesh. And Julie, could you go on to the next slide, please?
Fiona, can I just, there's a lot of concern. I can see a lot of concern around the 25% mortality that has been quoted at the beginning of the talk that's coming through on the chat. I think that is the figures that we have from a very early point in the disease process when we were learning a lot about the disease. And at that point, testing was restricted primarily to people who were admitted to hospital. There was not testing available for those people who may have had testing at home. So I really want to reiterate that to me would sound very scary, and I can tell that does sound scary, but it is a select group of people who came to hospital because their illness was severe. And those people at home, we don't have any data on that. And I think we do need to continue to learn from the data as we get through it. We're presenting the data that we have, and there will be over the next year more and more information coming out. So, and a lot of my patients did have COVID-19 who were asymptomatic, particularly my dialysis patients. A large portion of them never had any symptoms. We found it out on antibody testing, and there'll be a proportion of transplant patients who had COVID-19 who we don't know anything about the symptoms. So when we are presenting the data, we're presenting what we know now, but it is limited by where we were when we collected the data. I don't know if Rajesh has anything else to comment, because in the questions, I think there's it sounds very scary, and people are quite afraid that if they get COVID-19, that it really means that they are not going to survive.
I agree, Becky. I mean, that was the information what we had early on. I think that is something we all need to remember, that is not what we are saying at the moment the risks are. It is what we learned from a small group of people who became extremely unwell and needed in hospital care. there were a lot of patients who recovered from COVID and didn't have any issues. And also, I think this is where we will make sure that in a few months' time, with the transplants, what we are doing at the moment, certainly we'll be able to showcase the results of what we're doing at the moment and the outcomes. And I'm sure that will reassure patients as well.
Thank you. That's really well said, and that's really appreciated, because I think for everybody here, when you hear those figures, they are scary, but to put them in the context of what happened at the beginning of the pandemic and what is happening now and what we know now are quite different things. And I hope that people will feel a little, somewhat reassured by that. What I'd also like to say is that there are a lot of questions that continue to come through about working, especially if you work in schools, and we do know that there's a lot of concern about that. And so if you have those particular concerns and need that support with your employer, talk to our advocacy teams, because they've been doing a lot of work in that area to support you. So you're not alone on that. People were asking about mental health and the things that were available for that. Someone mentioned Kidney Beam, which is a nice innovation. We also have a counselling service, so we have counsellors available to help people talk through some of these things too, and we have a grant service too. So there are. You're not alone, I suppose, is the summary for that. I know that this is a really difficult time as we move from one phase to the next of the pandemic, and certainly at Kidney Care UK. And hopefully you can see from our fantastic medical colleagues who are here to support you, and the many more people behind that. There's a lot of people working very, very hard on this to provide the best service, the most honest answers we can give, and that we'll continue to give and continue to campaign for with my own personal hat on as we go through this. So if you have further questions, please let us have them after this session. We're looking as to whether to do further webinars, possibly once a month, on some of the issues that keep coming up. So please let us know that as well through the follow-up survey. And you're not alone, but thank you very much indeed for your time, for your attention, for your interest. And as long as we keep talking to each other, as long as we keep safe and do the sensible things, we've got a better than average chance of being able to get through this all fit and well. So on that note, unless anyone else has anything to say, I'd like to thank everybody. Thank you for your time. Please keep in touch, and see you soon. Thanks then. Thanks everybody. Bye-bye for now then. Bye-bye. Thanks.